Good morning, everyone. Welcome to San Antonio. Welcome to SABCS. We'll kick off with the clinical workshop. Every year, the clinical research workshop focuses on key elements related to clinical research. And it essentially sets the stage for important research that will be presented at the San Antonio Breast Cancer Symposium. So I'm excited to start the clinical research workshop. Our first presenter is Dr. Melinda Telli. Dr. Melinda Telli is the Associate Professor of Medicine in the Division of Medical Oncology at Stanford University School of Medicine, Director of the Breast Cancer Program at Stanford Cancer Institute, and Associate Director of the Women's Cancer Center. Dr. Telli's research focuses on the development of novel therapies for patients with triple-negative and hereditary cancer. Dr. Telli will review the use of post-neoadjuvant setting to accelerate drug development. Dr. Telli.
Well, good morning, everyone. It is my honor and pleasure to be here this morning to kick off the meeting and our clinical research workshop. Again, my name is Melinda Telli from Stanford University, and I am going to speak this morning on a topic that I think is a really important one related to using the post-neoadjuvant setting to accelerate drug development. So over the last few decades, we've learned a number of important lessons related to neoadjuvant therapy. We have learned that neoadjuvant treatment can convert surgically inoperable breast cancers to operable, that it can improve the rates of breast conservation, downstage the axilla by converting positive nodes to negative, and the NSABP B18 trial, which was reported now nearly 25 years ago, taught us that neoadjuvant treatment does not negatively impact outcomes compared with adjuvant therapy. And so in our quest to improve curative strategies for patients with early breast cancer, we have really learned to leverage the neoadjuvant platform to really assess response in individual patients. And we've learned that pathologic response at the time of surgery is really a strong surrogate for disease-free survival in responders, and this is particularly true in triple-negative as well as HER2-positive disease. And so the neoadjuvant platform today is really a wonderful platform to study breast cancer biology, but also to evaluate, prioritize new therapies for clinical development. And so this is just some data showing the relationship between pathologic response and relapse-free survival. And in this study, this response was evaluated using the residual cancer burden, or RCB index. And in this index, there are 4 levels. An RCB of 1 is a complete response. An RCB of 0 is a complete response. RCB 1 is minimal residual disease, shown here in gold. RCB 2 is moderate residual disease in gray. And then the red is RCB 3, extensive residual disease. And so you can see with increasing burden of residual disease that is associated with decreasing relapse-free survival. And this is true, again, across breast cancer subtypes, but we really see this separation in the triple-negative and HER2-positive subtypes most clearly. And so what we have been doing is delivering neoadjuvant therapy, assessing response at the time of surgery. Patients then go on to get radiation if clinically indicated, endocrine therapy, of course, if they're candidates for that. But generally, we just begin clinical surveillance and follow patients either for long-term survival or recurrence. But in the last 5 years or so, we have learned that there is really an opportunity to intervene, to give additional therapy in patients who do not achieve a complete response to their initial treatment. And so the CREATE-X study was really the first trial to challenge the dogma that additional adjuvant therapy didn't really have a role if the patient already received a complete course of chemotherapy in the preoperative setting. And so in this trial, patients with high-risk HER2-negative breast cancer who had residual disease after standard neoadjuvant chemotherapy received capecitabine or not in the adjuvant setting, and that was for 6 months duration. And you can see, this is showing here data from patients with triple-negative breast cancer, that capecitabine improved disease-free survival as well as overall survival with pretty significant absolute gains. And so this has now become part of our clinical practice, but I think it was really important to illustrate this idea that doing more can improve outcome. And shortly thereafter, we saw a similar story from the Catherine study, this time in high-risk HER2-positive disease where patients had residual cancer at surgery. And in this study, patients were randomized to receive TDM1 for 14 cycles or continued trastuzumab. And you can see that clearly there was a benefit for TDM1 in this study, an absolute disease-free survival gain of about 11% at 3 years. And this led to the initial FDA approval and indication for TDM1 in the curative setting. And then finally, most recently, we saw in the last year the results of the Olympia study. This was a study looking at escalation with olaparib in those patients with germline BRCA1 or 2 mutations and high-risk early breast cancer. And patients who had received neoadjuvant therapy would be eligible to enroll in this study if they did not achieve a complete response to their therapy. And they were randomized to receive olaparib for 1 year or placebo. And in the past year, we have seen the top-line results from the Olympia trial showing an improvement in disease-free survival, as well as most recently in overall survival. And this led to the FDA approval in the United States of this approach earlier this year. And so where are we now? I showed you examples that we have clearly demonstrated that in certain groups of patients, additional adjuvant therapy can improve survival. But I really think that at present, our approach and the way we select patients for this, it's really quite rudimentary. We select patients if they have residual disease in the breast or in the lymph nodes. And because most patients who have that never go on to have a recurrence, we're really over-treating a number of patients. And this is important as many of the therapies now entering into this post-neoadjuvant setting, they do come with increasing toxicity risks. And this has been hard because unlike in the neoadjuvant setting where we can look at pathologic response as a surrogate endpoint for outcome, in the adjuvant setting we really don't have a surrogate endpoint. And so we need to conduct large trials that are evaluating time to event endpoints like event-free or overall survival. And in the table, I'm just showing a few select studies that are ongoing right now in the post-neoadjuvant setting, looking at checkpoint blockade, other antibody drug conjugates, and you can see that these sample sizes are quite large, over 1,000 patients, some even over 1,500 patients. And so enter ctDNA minimal residual disease. I think we are really at the dawn of a new era with this technology, and it really has incredible potential to transform the way we make decisions for our patients with early stage high-risk breast cancer. And so we know that in breast cancer, if you detect ctDNA positivity after treatment, that this is associated very strongly with recurrence risk. And so here you can see that the hazard ratio for relapse-free survival is 16.7, looking at those that are ctDNA positive versus negative. And I think what's also important with this study is that it's really true across breast cancer subtype, looking at the ER-positive disease on the top, HER2-positive disease, and also triple-negative disease. And so the real question is, if we find it, can we act on it? And so we would like to act on it to really change the trajectory of the disease course for the patient. And certainly this technology gives us an opportunity to do that and study that. There are a number of new and highly sensitive ctDNA assays that are available and in development, and all of these have really been able to improve our ability to detect MRD. And so while I don't have a lot of time to cover that right now, in this talk I will point you to an education session on Thursday afternoon, what ctDNA can tell us, and I think it's going to go into a lot more detail about some of these assays and their pluses and minuses. But what I really wanted to talk about was the new FDA guidance that was released in May of this year, looking at the use of circulating tumor DNA for early-stage solid tumor drug development. So this is guidance for industry. And in the document, the FDA states that ctDNA as a biomarker has a number of potential regulatory and clinical uses in the early stage setting, and that it may assist with and expedite drug development. And so in this guidance, the FDA lays out 4 potential uses in early stage solid tumors. 1, ctDNA for patient selection based on a molecular alteration. 2, ctDNA molecular residual disease for patient enrichment. ctDNA as a measure of response or as an early endpoint in clinical trials. And so if we just focus in on the ctDNA molecular residual disease for patient enrichment guidance, a few key points. So ctDNA testing can be used to determine study eligibility. For example, if you wanted to identify a biomarker positive population. It can also be used as a stratification factor in a trial where you're enrolling both positive and negative patients, and you can design and use hierarchical testing of multiple endpoints in the intent to treat and also in the ctDNA positive groups. It can support randomized trials of either escalation or de-escalation, but importantly, the primary endpoint for these studies should be survival and not clearance of ctDNA. And so I want to just go over an example of how perhaps this guidance in the future might help us to avoid missing a signal in a phase 3 trial. And the case I want to talk about is IMvigor10. So this was a phase 3 trial, and it looked at adjuvant atezolizumab or observation in patients with high-risk urothelial cancer. Most of these patients had bladder cancer treated with neoadjuvant therapy and had residual disease at the time of their surgery. And so you can see the primary study results here. Among 809 patients, there was no benefit in terms of either disease-free or overall survival with 1 year of atezolizumab therapy. However, they did do a subsequent analysis in the biomarker evaluable population, 581 patients, and were able to determine MRD status in 508, and of those, 214 were positive. And so if you look at the data again, you can see that regarding disease-free and overall survival, There was really no difference in those patients that were ctDNA negative, but in those that were ctDNA positive, there was a clear benefit and advantage for the 1 year of atezolizumab with a hazard ratio of approximately 0.58. So in this phase 3 study, that signal was missed, and again, if we think about the future, potentially this signal could have been identified with only a few hundred patients instead of more than 800. And so what about breast cancer? What data do we have? We do have data from a trial really of quite similar design to IMvigor10, and that was the CTEC-TRAC triple negative study. This was a study, phase 2, for patients with high-risk early-stage triple-negative breast cancer. After they completed their curative intent treatment, they began ctDNA surveillance, and if they were positive, they were then randomized to the intervention, pembrolizumab, for 1 year or observation. But after the randomization and prior to treatment, staging was specified in the protocol. And so you can see the co-primary endpoints here, rates of ctDNA detection at 12 and 24 months, as well as the rates of sustained ctDNA clearance among those patients on pembrolizumab. I broke the patients down into those at high risk versus moderate risk, and you can see the criteria. And of just over 200 patients that were enrolled at the end of the day, 161 patients went through the surveillance testing. And at a median of 20 months, the proportion of patients that were ctDNA positive at the 12-month time point was 27.3%. And you can see on the right that it was certainly much higher in those with clinical high risk. So these were largely the patients with positive nodes, large burden, or residual nodal disease after neoadjuvant therapy. So the rate there was over 55%, and among those with moderate risk, it was 11.8%. And so what about the study? So there were 45 patients that were ctDNA positive, and they entered into the therapeutic trial. And unfortunately, and quite shockingly, I'd say, when the patients underwent their staging, just around 72% of them actually had overt metastatic disease. And so there were only 9 patients that were ctDNA positive and staging negative, and only 5 of those started the pembrolizumab, and none exhibited sustained clearance. So I think this is really a cautionary tale that this approach, while it makes a lot of sense, that it may be more complicated than we may have thought in terms of really trying to find the patients and offer the intervention. There is another phase 3 trial that is ongoing and enrolling patients right now, looking at an MRD-directed approach, and this is the phase 3 ZEST study, evaluating niraparib or placebo in MRD-positive patients with either a tumor BRCA mutation or BRCA wild-type triple-negative breast cancer. And so certainly there is going to be a lot of learning from this trial for the field as we really push this MRD-directed treatment approach forward. And so while I have focused a lot on the post-neoadjuvant setting, certainly opportunities for MRD in early breast cancer are many. So we've been talking about the high risk and the ability to potentially identify those with persistent risk after they have completed standard treatment. And if we can design trials where we enrich for that group, the hope is that our trials could be smaller and more likely to be successful. But there's also potential application for low-risk disease. So thinking about those situations potentially where treatment could be withheld. So you could think about small node negative, triple negative, or HER2 positive tumors. But then there's also the approach of right-sizing treatment. So you may have a patient who was initially high risk, had a good response to their preoperative therapy, and so questions that one could ask is whether the subsequent adjuvant therapy could be shortened or potentially omitted if they have had a good response to that treatment and are MRD negative. And you could also consider questions like this one. And so this is really an approach to look at ctDNA clearance in a window type of study with really the goal to prioritize treatments to move forward into phase 3 testing. And this example is with triple-negative breast cancer, where patients that are MRD positive are randomized to an investigational therapy versus control, in this case capecitabine. But they're given that treatment just for a short window of exposure, and then rates of clearance at 8 weeks. Clearance of the ctDNA is evaluated as the primary endpoint. And so to conclude, I think it is really an exciting time to be a clinical trialist in breast cancer. We will have our work cut out for us over the coming years as we really try to learn how to best leverage ctDNA MRD in high-risk early breast cancer. There are a number of questions that are really important that we need to answer. When and how frequently should we perform the MRD assessment? Certainly we need to start screening early enough while there's still an opportunity to intervene and alter that disease course. But given the elevated risk of early recurrence for certain breast cancer subtypes, we can't wait really long intervals between those assessments. Which assays? There's many questions around this. There are both tumor-informed and tumor-agnostic assays that both have their pros and cons, and so we really need to better understand what is the best assay or assays for breast cancer. And then who to test. If we test those at very high risk of recurrence, the CTRAC triple-negative study suggested that maybe those aren't the best candidates for this approach because of their really high risk of early recurrence. But if you select patients that are too low risk, then your yield for identifying patients that are positive is low, and you have to screen a lot of patients. And then we also need to think about subtype-specific differences in ctDNA kinetics, as well as tumor shedding. And so all very important things to consider as we move forward. And I think that with thoughtful and innovative clinical trial designs, we should be able to really answer these questions to determine the ultimate role of MRD in early breast cancer. And with that, I thank you.
Thank you so much, Dr. Telli, for the excellent presentation. We will open it up for Q&A. Come up to the mic and ask a question. As folks are coming up, maybe I'll start with the first question. Dr. Telli, the ZEST trial is a very important trial because it's looking at the use of therapy in patients who are ctDNA positive, so could establish clinical utility of doing ctDNA analysis. Could you comment on the type of assay that's used in that trial and any key considerations in terms of study design and operations for future ctDNA-based studies?
Yeah, great question. So in that trial, the assay that is being used is a tumor-informed assay. And so with that type of assay, you have to submit a sample of a patient's tumor, and whole exome sequencing is performed of the tumor as well as the germline. And then with that assay, this is the Signatera assay, 16 tumor-specific variants are selected to be tracked over time. And so certainly there are a number of advantages of tracking multiple alterations and making the assay tumor-informed. But there are challenges in real-world clinical practice. You have to get the tumor block. You have to submit it, and sometimes for those patients who were treated with neoadjuvant therapy, they may not have a lot of tumor remaining, and so there can be challenges in some patients being able to actually generate an assay. And so this is where potentially the tumor agnostic assays really have an advantage. All you need to do is get a blood sample, and you don't need archival tumor tissue. So these are some of the points that I think as we move forward, we really need to determine what is the best approach and how should we proceed with these.
Microphone.
Hi, good morning. Thank you for the presentation. It was very nice. Gonzalo Espera from Trio. Based on the information that you have shared and that we know, those patients which have residual disease after neoadjuvant therapy have an elevated risk of disease recurrence. Do you perform any different follow-up in this patient population? Because based on the guidelines, it is not very well separated what is the follow-up that should be performed in this kind of patients. What is your approach?
Yeah, so the question, if I understand, is approach to clinical follow-up for those patients with residual disease. Yeah. So at this point, my approach, and I think it's endorsed by guidelines, is to really just follow the patients clinically. We get the breast imaging as appropriate on at least an annual basis. But there's not really any other imaging or testing that is done. Certainly we know that those patients are at elevated risk, and so I like to see them pretty frequently for the first few years. Yes, we're not doing MRD testing, we're not doing any imaging, right, to identify early relapse at this point.
Thank you. And do you change your approach based on ctDNAs?
Well, we hope that in the future, when we have data to support the utility of ctDNA, that we will change our approach. And I think, this is really the challenge of our time right now in early breast cancer, understanding if we can change our approach and have it make a difference for patients. So at this point in time, it's just all investigational.
Thank you very much.
Thank you. We're right on time.
Okay.
Thank you again, Dr. Telli, for
right.
the excellent
Thank you.
presentation.
Sorry for the technical challenges.